Myself, Dr. Pranali Katre, coordinating today's session
with
with
Dr.
Dr.
Jagrati Fatima.
And hello.
Please go ahead, Dr. Pranali.
I would request participants to mute your mic. I am delighted to welcome you all to this much awaited webinar of this NIMA-National Central webinar series. Before starting our session, I request all the dignitaries and the participants to take a moment for blessing of Lord Dhanvantari. I would like to call Dr. Jagrati Patil for Dhanvantari Stavan.
नमामि धन्वन्तरिमादि देवम् सुरासुरैर्वन्दितपादपद्मम् लोके जरार भयमृत्युनाशनम् दातारमीशम् विविधौषधीनाम् शङ्खं चक्रं जलौकां ददतमृतघटं चारुदुर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्बोजनेत्रं कालाम्बोदुज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं
Doppler involved interpretation in all times. अरे वो धन्वंतरी है।
प्रौढदावाग्निनीलम्
Thank you, Dr. Jagrati. May Lord Dhanvantari
Thank you,
bless
Dr.
us all with good health and great success. Now let's continue and begin this webinar. On behalf of NIMA-National Central, I welcome all the dignitaries and delegates for today's knowledge enhancing session on the topic of Doppler assessment in second
and third trimester. First of all, I welcome President of NIMA Central, Dr. Ashutosh Kulkarni sir, Secretary of NIMA Central, Dr. U.S. Pandey sir, and Treasurer of NIMA Central, Dr. Shantilal Sharma sir. Now, I would like to welcome Dr. Kamini Dhiman ma'am, President of NIMA OBGY Central, Dr. Priyanka Nakhade ma'am, Secretary of NIMA OBGY Central, Dr. Vishnu Bhavne sir, Treasurer of NIMA OBGY Central, and Dr. Rajesh Utane sir, Convener of NIMA OBGY Central. I would also like to welcome Dr. Suhas Herlekar sir, President of NIMA OBGY Maharashtra, Dr. Manoj Gaikwad sir, Secretary NIMA OBGY Maharashtra, and Dr. Ajay Raj Bal sir, Treasurer NIMA OBGY Maharashtra. Welcome you all. So, before we go any further, let me give you a few instructions that are common for all participants. Please, everyone keep yourself muted during session. If your mic found unmuted or disturbing with speaker's voice, then you will be either kept in waiting room or removed from the session to maintain decorum of the program. If you have any questions, put your questions in the chat box or raise your hand. Now, I would like to brief everyone here about our NIMA OBGY agenda. I request all the participants to mute your mic. Now, I would like to brief everyone with our NIMA OBGY agenda. NIMA OBGY, that is National Integrated Medical Association, Obstetric and Gynecological Society of India, aims to impart education in supporting and protecting the character, status, and interests of the integrated medical profession in general practitioners and practitioners of Srirog and Prasuti Tantra, that is Integrated Obstetric and Gynecology in India. Our aim is to spread knowledge and to foster education in integrated obstetrics and gynecology, including human reproduction, family welfare, study and research in the field of contraception and other allied problems. NIMA OBGY is committed to promote services for betterment of health of the community, especially maternal and child health, prevention of ailments and diseases, and the treatment with integrated approach of Indian medicine with modern science. So let us continue with our 34th webinar in this series. As you all know, today's topic of webinar is Doppler assessment in second and third trimester. Doppler assessment of the placental circulation plays an important role in screening for impaired placentation and its complication of preeclampsia, intrauterine growth restriction, and perinatal death. Assessment of fetal circulation is essential in the better understanding of the pathophysiology of a wide range of pathological pregnancies and their clinical management. So we are here to understand detailed knowledge about Doppler's assessment in pregnancy. Today we are very lucky to have here with us distinguished clinician Dr. Priya Sahu ma'am. She will guide us through her novel thoughts regarding this topic. So we welcome you ma'am. We are honored to have you with us. It's my pleasure to introduce all of you Dr. Priya Sahu ma'am. Dr.
Thank
Priya,
you, such a warm introduction. Good evening, everyone. I am Dr. Priya Sahu. I am a fetal medicine expert practicing in Nagpur. The topic which has been given to me is Doppler, its importance in all the trimesters. So,
sorry ma'am. I want to give you just a small introduction. May I?
okay, yes.
Dr. Priya Sahu, ma'am. She is Director of New Bliss Fetal Care, Ramdaspet, Nagpur. She is working as a consultant at Omega and Icon Hospital, Nagpur. She has pursued her MBBS degree from Dr. B.R. Ambedkar Medical College and Master degree in OBGY from Rajeshwari Medical College and Hospital, Bangalore. She has completed fellowship in fetal medicine under Dr. Pratima Radhakrishnan at Bangalore Fetal Medicine Center. She has certified for NT-scan, anomaly scan, Doppler scan by FMF UK. She also certified in advanced ultrasound and invasive procedure from Chikitsa Ultrasound Training Center, Mumbai. She is member of Maharashtra Fetal Medicine Society. She is also member of Nagpur Obstetric and Gynecological Society. She is a part of various teaching programs and also work as assistant professor. She is invited regularly as a guest speaker at various regional and national conferences. Her special areas of interest are invasive procedures, high-risk pregnancy, fetal neurosonography, fetal echocardiography, genetic counseling, and many more. So, with due respect, I would like to call such a versatile person, Dr. Priya Sahu ma'am, to start session. Welcome, ma'am.
Thank you so much. The topic which has been, I hope everyone can see my screen.
Yes, ma'am.
Yeah, okay. The topic which has been assigned to me is Doppler, its importance and interpretation in all the trimesters. Yes. So Doppler is an integral part of all the obstetric scan. Whenever a woman comes to us for an antenatal checkup, Doppler is a must. It is a non-invasive modality which helps us to assess both maternal and fetal blood circulation. It helps us to predict complications like preeclampsia, low birth weight, IUGR, placental insufficiency. It helps us to manage and diagnose disorders in pregnancy. In uncomplicated cases, it helps us, it assures both the mother and the obstetrician. The basic principle of Doppler is what we capture the movement of blood flow. The Doppler waveform usually looks something like this. This Doppler waveform tells us about the peak systolic velocity. S stands for peak systolic velocity. D stands for end diastolic velocity. Using these systolic and diastolic velocities, we generate indices known as PI, RI. PI has linear correlation with the vascular resistance. Higher the PI, the more is the resistance. This is the most important point. SD ratio was prior used, is no longer in existence right now, has minimal significance. PI is the most commonly used index in current practice. Coming to the flow imaging modalities, that's the screen shows the panel on the ultrasound machine where we can see there is color flow, spectral or pulse wave Doppler, power or energy Doppler. The CF stands here for the color flow, PD stands for the pulse power Doppler, and pulse PW stands for the power or pulse wave Doppler. What are the basics required of the basic equipment required in order to evaluate the fetoplacental circulation? The equipment, the machine should be enabled with color flow, pulse wave Doppler, There should be on-screen display of pulse repetition frequency. Ultrasound frequency should be displayed in megahertz. There is something called as mechanical index, thermal index, which should be displayed on the ultrasound screen. There should be a software which must be able to estimate the peak systolic volume and diastolic velocity and calculate the Doppler indices like PI, RI, and SD. Pulse wave Doppler, how to optimize is the best recordings are obtained when there is absence of fetal breathing and absence of any body movement. Also, you can ask for a temporary maternal breath hold to get optimal measurements of the Doppler. There should be optimal insonation. There should be wide Doppler gate. What is the role of Doppler trimester wise? First trimester, it is very important to rule out any preeclampsia, to rule out aneuploidies, to rule out congenital anomalies. Second trimester, preeclampsia and congenital anomalies. I will get into the detail of it later. Third trimester, mainly Doppler is used for IUGR. What are the routinely imaged vessels or what are the vessels of our interest? In first trimester, ductus venosus, tricuspid valve, uterine artery are our vessels of interest. Second trimester, uterine artery, umbilical artery. Third trimester, umbilical artery, MCA, and the uterine artery. There are other Dopplers as well, also known as ductus venosus Doppler, aortic isthmus Doppler, umbilical vein Doppler, IVC. These are performed only in special cases and when we suspect something abnormal in second and third trimesters. Coming to the first trimester, ductus venosus is a very important vessel. It helps us. It is basically a shunt between the umbilical vein and the inferior vena cava. It is a trumpet-shaped vessel. It shunts majority of the oxygenated blood through the umbilical, which is coming through the umbilical vein, through the placenta to the umbilical vein, then to the ductus venosus goes shunts directly into the right atrium through the inferior vena cava. This is the waveform this is the waveform what we get when we apply the pulse wave frequency at the ductus venosus. S stands for the ventricular systole, D stands for early diastole, A stands for contraction. Now, what is the significance of ductus venosus? As you can see, this is the normal waveform. As you can see, this is the normal ductus venosus waveform. Here is the A wave, which appears normal to us. That's the A wave here. While in cases when there is reversal of A wave, you can see that A wave has reversed. This has got some significance. Reversed A wave along with increased NT in the first trimester is known to be associated with chromosomal abnormalities, in particular Down syndrome. It also tells us because ductus venosus flow also tells us about the cardiac condition of the fetus. So it also helps us to rule out cardiac abnormalities. If there is reversal of A wave, we can predict adverse perinatal outcomes. In third trimester, when we have abnormal umbilical artery flow, abnormal middle cerebral artery flow, ductus venosus comes into role to decide when to deliver. So ductus venosus is not just important to rule out chromosomal abnormalities or to predict chromosomal abnormalities. It also helps in management of IUGR. Ductus venosus is very important in case of twins, especially in monochorionic twins and in any higher order pregnancy, and helps us to manage the patient throughout. Ductus venosus, the A wave reversal which I'm talking about can also be abnormal in 1% of the normal fetuses. So ductus venosus improves our first trimester combined screening. There's also something called a tricuspid valve Doppler. Here, we apply the pulse wave or the sample gate across the tricuspid valve and try to get a waveform. This is the normal waveform of a tricuspid valve, which is tricuspid valve plays important role in screening for aneuploidy, again for chromosomal abnormalities like Down syndrome, Edwards syndrome, and to rule out any cardiac abnormality. So we saw that this is the normal waveform with no regurgitation across the tricuspid valve. We go further. This is what you can see is the regurgitation. So this is abnormal. isolated tricuspid regurgitation, we should subject the mother for fetal echo, and we should also, when it is associated with increased NT, it again tells us that the baby could be aneuploidic. So again, both ductus venosus and tricuspid valve Doppler, it improves the performance of first trimester combined screening. So coming to uterine artery assessment, it is an important non-invasive screening tool which is to be done in almost all the obstetric scans. There is evidence that in high proportion of pregnancies who are destined to develop preeclampsia, the uterine artery PI is increased at 11 to 13 weeks. So whenever a report comes to you with NT scan, please look for the uterine artery Doppler so that we can advocate aspirin therapy if the uterine artery PI is abnormal. So uterine artery is an important predictor for preeclampsia, FGR, low birth weight babies, maternal morbidity and maternal mortality as well. So coming to the uterine vasculature, uterine artery is usually in the earlier gestation is a high resistant vessel. As you can see, the trophoblastic invasion of the uterine arteries is yet to happen in the first trimester. So we can see a notch, which is also known as the physiological notch, which is always seen in first trimester, and it is normal. The trophoblastic, after the trophoblastic invasion starts, the high resistant vessel becomes a low resistant vessel. As you can see, the diameter of the vessel also is increased. The notch disappears. That happens in the early second trimester, and by 24 to 26 weeks, all the notches, they usually disappear. If there is persistence of notch after 24 to 26 weeks, it is impending of deficiency of uterine blood flow. So when to screen? Best time to screen for a uterine artery Doppler is 11 to 13 weeks. Why 11 to 13 weeks? We can of course screen it later as well, even at the time of anomaly scan. But 11 to 13 weeks, we buy time to advocate aspirin therapy, because aspirin therapy works very well if started before 16 weeks. 150 milligram of aspirin to be started in all the mothers who have increased uterine artery PI. Second trimester, if there is increased uterine artery PI, of course, it helps us to categorize women into low risk and high risk groups. So what is the significance? Mean PI more than 95th centile in uterine artery is abnormal and is pathological. It tells us that the outcome can be poor. So according to the ASPER trial, in the ASPER study, women were screened for preeclampsia at 11 to 13 weeks. In the high risk group, use of aspirin 150 milligram per day from 12 weeks until 36 weeks was done. It reduced the incidence of preeclampsia before 34 weeks by 80%. So aspirin 150 milligram, if started before 16 weeks, it reduces the incidence of preterm preeclampsia by 80%. So notching may be subjective sometimes, but PI more than 95th centile is pathological. Uh, Grossly, if we are, there are charts available for the uterine artery. If we do not have a chart, then by 12 weeks, the cutoff is 2.58. By 24 weeks, the cutoff is 1.56. This will be 95th centile for those particular weeks. Coming to second trimester, Doppler helps us to predict congenital abnormalities, predicting preeclampsia, monitoring in fetal anemia when the MCA-PSV is more than 1.5 moms. It helps in monochorionic and dichorionic twins. Coming to the congenital anomalies, how does Doppler helps us in congenital anomaly? As you can see, there is that's the heart showing the four-chamber view. We can see the color flow across the ventricles, and we can rule out any form of ventricular septum defects or any flow abnormalities. Here you can see that's the that's the corpus callosum. Here you can see there is an aneurysm. So all these things can be picked up with Doppler. Coming to third trimester, the role of Doppler in third trimester basically confined to fetal growth restriction. Umbilical artery, which is another one important artery which helps us to manage FGR babies. Umbilical artery at 11 to 12 weeks shows absent diastolic flow. That's the systolic flow here. There is no flow here across here. So that this shows absent diastolic flow. At umbilical artery at around 18 weeks shows shows relatively high resistance, but there is some diastolic flow. That coming to 28 weeks, there is low resistance and there is very good diastolic flow. And at 32 weeks, there is generous diastolic flow. So this is how a normal umbilical artery waveform looks through 11 weeks to 32 weeks. Umbilical artery Doppler, what are the indications? Whenever there is IUGR or estimated fetal weight or abdominal circumference is less than 10 centile, we offer umbilical artery Doppler. There is oligo, there are placental changes, there is low papae, the uterine artery PI is increased, there is preeclampsia. Umbilical artery Doppler waveform helps us to identify fetuses at the risk of hypoxia. So that's the umbilical artery. We often take a waveform from the free loop. When there is high resistant flow, we suspect placental dysfunction. When there is absent diastolic flow, as you can see in this picture, there is absent diastolic flow. We suspect hypoxia. And when there is reversal of flow, you can see there is reversal of flow here. We suspect severe hypoxia. So PI more than 95th centile is pathological. So coming to the MCA Doppler, at any period of gestation, MCA is high resistant circulation. The PI will be high. That I'll tell you how. Um, uh, with continuous forward flow throughout the cardiac cycle. Low diastolic flow is seen in cases when the baby is young or the gestational age is less, or when we apply a lot of pressure, there can be absent diastolic flow, and there can be increased diastolic. The maximum diastolic flow is seen in third trimester, that is beyond 34 weeks. When the MCA PI is less than the fifth centile, it is known as pathological and is suggestive of brain sparing effect. So the umbilical artery, when the PI is 95th centile, it is abnormal. MCA, when the PI is below the fifth centile, it is normal, because fetal circulation or the fetal cerebral circulation usually has high resistance, but in cases of placental dysfunction, that high resistant circulation turns into a low resistant circulation. That is what is known as brain sparing. That means only the blood supply is channelized to the brain. So PI below fifth centile is pathological. So normal umbilical PI, there are charts available, but grossly normal umbilical PI should be around 1.5 to 2. Now, what is cerebroplacental ratio? Cerebroplacental ratio, when we divide MCA PI with the umbilical PI, we get a number. Usually more than one is considered normal and less than one is considered abnormal. There are charts available for this as well. It improves we have two important vessels, that is umbilical artery and the MCA, but together when we divide MCA with umbilical PI, we get a ratio which is CPR, and it is more sensitive and helps us more. So but CPR below fifth centile is again pathological. Aortic isthmus Doppler is used, it can be done, but in special cases only. Now we have a baby, we have a small fetus whose abdominal circumference or the estimated fetal weight is below 10th centile. We look into the Dopplers. If the Dopplers are normal, we label it as small for gestational age baby. And if the Doppler is abnormal, we will label it as fetal growth restricted baby. Now, what is the criteria for FGR? Depending on the gestation, if we diagnose it before 32 weeks, it is known as early onset. If we diagnose it later, it is also late onset IUGR. The parameters which we look into in order to diagnose FGR are abdominal circumference, estimated fetal weight. If it is less than third centile at any point of gestation, we can label the baby as FGR. Also, umbilical artery Doppler, if there is absent end diastolic flow, we saw in the previous slide how absent end diastolic flow looks like. So if it is absent end diastolic flow, we label the baby as FGR baby. Also, if there is growth restriction, the Dopplers which we are interested into will be uterine artery and umbilical artery if it is if the baby is less than 32 weeks. If it is more than 32 weeks, we will look into the CPR, MCA, and the umbilical artery. So these are the criterias. Basically, if the abdominal circumference and the effective fetal weight is less than third centile, we label it as IUGR. Early onset IUGR, comprises of 20 to 30% of all the FGRs. Late onset, 7 to 80% of all the FGRs. Prematurity is the major concern in early onset FGR, while in late onset, it is not so. They are usually 50% of the times associated with preeclampsia, and least sometimes around 10% of the times late onset is associated with preeclampsia. Placental insufficiency is more in case of early onset, and there is chronic hypoxia. Usually the baby is immature and they have higher tolerance to hypoxia. These babies with early onset IUGR have high mortality and high morbidity ratio. However, late onset FGR, there is lower mortality, but the long-term outcome can be poor. So there are some Barcelona protocols which tells us about if there is mild placental disease and severe placental disease with hypoxia, if there is low suspicion of acidosis or high suspicion of acidosis. So coming to these Barcelona protocols of how to monitor a pregnancy with IUGR. If the effective fetal weight is less than third centile, or cerebroplacental ratio is less than fifth centile, or the umbilical artery PI is more than 95th centile, MCA PI is less than fifth centile, or the uterine artery PI is more than 95th centile, if any of this is there, we suspect there is mild placental insufficiency and this baby requires weekly monitoring, and we would like to deliver this baby by 37 weeks with labor induction. When there is absent end diastolic flow in the umbilical artery, we are suspecting a severe placental insufficiency, and we are expecting we will be wanting to monitor this baby bi-weekly and deliver the baby by 34 weeks and prefer a cesarean section. When there is acidosis, or when we are suspecting there is low suspicion of acidosis, as in case of reversal in umbilical artery, we will monitor the baby every 2 days, and we would like to do a cesarean at 30 weeks. When there is DV reversal, we will like to monitor the baby every 12 hours, and we suspect there is fetal acidosis, and we will deliver the baby by 26 weeks by cesarean section. This has been issued by the International Society of Ultrasound and Obstetrics and Gynecology. This is a very useful chart where we know there is a FGR fetus and we know what gestation is baby is falling into, and we look into the Doppler, that is umbilical artery Doppler, whether it is absent or reverse end diastolic flow. And then we do, then we look into the DV and decide when we would like to deliver this baby. So the role in the management of IUGR is we have to weigh prematurity and hypoxia and get a personalized management plan for the baby for the best outcome. So coming to our cases, we had a 30-year-old primate with low PAPE. Low PAPE is known to be associated with IUGR. So what is the role of Doppler here? So here we would like to ask the mother to come for serial growth scans. We will put this baby into the radar of monitoring, and we will ask the mother to come for serial growth scans along with Doppler to diagnose and manage IUGR if there is any. 30-year-old primate with previous IOD, previous eclampsia, came for anomaly scan at 20 weeks for a routine checkup. What is the role of Doppler here? First of all, as we all know that uterine artery is an important predictor for preeclampsia or for IUGR, we would like to do a uterine artery Doppler, and again, we would ask for serial growth scans. A 29-year-old primate, preeclamptic, came to us at 27 weeks. AC was at 23 weeks. That means approximately 4 weeks lag was there. So we can label this baby as an IUGR baby, and the umbilical artery showed absent end diastolic flow. So what we would like to do? So our baby is FGR baby. The baby is 27 weeker, as you can see. There is absent end diastolic flow in the umbilical artery. So we will be delivering this baby on the basis of the ductus venosus and the umbilical artery. Ductus venosus, how we will look into it, how is the A wave, or we will see the umbilical artery, whether there is reverse end diastolic flow, and deliver accordingly. So the take home message here will be ductus venosus, tricuspid valve Doppler improve first trimester screening. Ductus venosus can help us to manage babies with IUGR. Uterine artery Doppler to be done with NT scan, as it helps in early prediction of preeclampsia and advocating aspirin therapy. Umbilical artery, if more than 95th centile, is pathological. 2.6 in first trimester is the cutoff. 1.4, 1.45 or 46 is the cutoff in second trimester. MCAPI less than fifth centile is pathological and is suggestive of brain sparing effect. CPR less than fifth centile is again pathological. When to deliver? Always weigh prematurity and hypoxia and then decide the management. Thank you.
Ma'am?
Yeah, yes. Any questions from the audience?
Hello.
Yeah, ma'am. Thank you so much for this wonderful and very informative session. You explained this new topic so nicely to us. Now, what I would like to call Dr. Jagrati Patil, ma'am, to take further question and answer session.
Thank you, Dr. Brunali.
Dr. Taj.
Ma'am, am I audible?
You're not
Yes.
that audible.
Hello.
Dr. Jagruti, your voice is coming very low.
Am I audible, ma'am?
Yes, now you're audible.
Yes, yes.
Ma'am, if you permit, shall we start with the question and answer session regarding this
Yes,
topic?
yes, please.
So my first question is, ma'am, if there is RH incompatibility at
Yes.
initial level, when should we do MCA PSV?
MCA-PSV, usually the MCA-PSV can be done around 20 to 23 weeks to rule out fetal anemia. And you can also do at 16 and 18 weeks, but 20 to 23 weeks will be better.
Okay, thank you, ma'am. I request all the participants, if you have any query or question, please put your question in the chat box. Ma'am, the second question is, can fetal stroke be diagnosed through the Doppler, and what is its significance?
Can
Fetal stroke.
fetal stroke, cardiac asystole,
Yes.
or cardiac arrhythmias. Um, Yes, we not really, but of course the baby might do well. We can might do bad, like some baby might develop hydrops, or baby might have some other signs or some cardiac abnormality, some regurgitation somewhere. So we can suspect. We cannot diagnose it actually.
Okay, ma'am. Uh, the next question is, what is the alarming PI value of umbilical artery at each trimester? Means very dangerous value.
Okay, there are charts available for each trimester. What happens? Usually one point. Usually, what happens? When you put the reading in the chart, there are also calculators available for each gestation. It is different. Yeah. Hello. Yes.
I request participant to mute your mic.
Ma'am, please continue.
Yeah.
Yes, even 1.2, 1.3 can be normal if you put it in the calculator and see for 32 weeks, and also zero point 0.8 is normal for 34, 36 weeks. So it totally depends on the gestation. For each week, there is a different PI, which will be 95th centile. So you need to refer to the chart.
Okay, thank you so much, ma'am. Ma'am, the next question is, are there any tests related to Doppler to assess carcinoma or CA in the fetus?
No, actually, there are no tests per se now. What carcinoma are you suspecting? Through Doppler, we cannot do anything about it.
Okay.
We can, of course, through invasive procedures, we can rule out genetic problems. We can do an amniocentesis if mother is suffering from something, or the family is suffering from some disease, genetic disease. Yes, and we have the study available or the gene mutation responsible for it available. We can do an amniocentesis and we can figure out for the baby.
Okay. Thank you so much, ma'am. Uh, the next question is, in IUGR, if SD ratio of umbilical artery is normal, can we delay the pregnancy till term, or at what limit we can take decision to terminate
SD
the
ratio,
pregnancy?
my presentation, some 7 to 8 slides says SD ratio is no longer used. PI is what we are looking into. PI is the most significant thing. So if PI is normal, of course, we will take the pregnancy to term.
Okay, okay. And why should we prefer PI rather than SD ratio?
Because PI should be preferred because SD ratio, there are variations. There have been studies which are done, and they say SD ratio, the outcome was not that great. Monitoring PI was better than monitoring the SD ratios.
Okay, thank you so much, ma'am. Here is the question from Dr. Rishikesh Bagmare, sir. The question is frequency of Doppler in twin-to-twin transfusion syndrome.
Mhm. Frequency of Doppler in twin-to-twin transfusion syndrome. Twin to twin means that it is a monochorionic pregnancy. Monochorionic pregnancy, normally, even if there is no twin to twin transfusion, we advise from 16 weeks, every 2 weeks, Doppler should be done when there is no TTTS. If there is TTTS, we might have to call the mother weekly.
Okay, okay.
In normal monochorionic pregnancies, we would like to monitor the baby every 2 weeks. This is the rule from 16 weeks onwards.
Okay. The next question from Dr. Rishikesh Bagmare is the same screening schedule weekly or fortnightly?
Jagrati, you're not that audible actually. Your voice is very low. It's very difficult for me to listen to your questions.
Hello, ma'am. Am I audible?
Yeah, yeah,
Ma'am, your
yeah,
voice
better,
is
better.
too low.
Hello.
Yeah, yes, Jagrati.
Yes. Is it clear?
Yes, yes,
Yes. The next question from Dr. Rishikesh Wagmare sir is the same that you have answered already. The screening will be fortnightly or weekly.
yes.
I think you have answered this question. Now the next question is, how do we judge fetal anemia through MCA flow pattern?
Okay, fetal anemia through MCA. MCA Doppler, usually we have calculators to calculate fetal anemia. When we do MCA Doppler, it tells us about the peak systolic velocity. So if we put that peak systolic velocity in our calculator and the gestational age, and if it is more than 1.5 moms, we suspect that there is fetal anemia. But usually the cutoff, usually the peak systolic volume is considered to be, velocity is considered to be 60. If it is more than 60, we consider it abnormal and we are highly suspicious of anemia. There are calculators available in Fetal Medicine Foundation website where we put the gestational age and we put the PSV of the baby or the MCA PSV. And it should, if it is more than 1.5 moms, we are suspecting anemia.
Okay, thank you so much, ma'am. Here is the question from Dr. Smita. Uh, as you have explained about studies done with EcoSpring, when should we choose injection low molecular weight heparin and when tablet EcoSpring?
Low molecular weight heparin always works better. And of course, you can, once the patient is with BOH or any other autoimmune or any condition, immune condition we are suspecting, we can start low molecular weight heparin as soon as the mother is, we get to know she's pregnant. And of course, low molecular weight heparin will be better.
Okay. Thank you so much, ma'am. The next question is from Dr. Pooja Pandey. If CPR changes from 1% to 1 percentile to 5th percentile at different scans in the couple of states, then how to decide what CPR to rely on, or
Okay.
is it
CPR
that
is something, the MCAPI is something which changes sometimes, it even if you apply a lot of pressure. So it happens that once first centile, if it is fifth centile now, then also it is alarming. And we have to look to the umbilical flow. How is the umbilical flow? How is the diastolic flow? If CPR is non-reliable, umbilical artery, we can look into the umbilical artery, whether there is absent diastolic flow, whether there is just increased PI. We can look into the DV if you feel that this CPR is unreliable.
okay? Thank you so much, ma'am.
Whether it is first centile or fifth centile, of course, it is the baby has come into the higher risk zone and should be monitored.
Okay, ma'am. Ma'am, the next question is, while assessing MCA, which normally has higher impedance, generally indices of resistance in MCA are low in association with fetal compromise, overlap with lower part of normal limit in many small fetuses. So how can we differentiate and recognize the deteriorating situation?
Jagrati, I really can't hear you. I really can't hear you.
Is it audible, ma'am?
It's audible, but the
You are
volume is
audible,
very low.
but yes, volume is very less, Jagruti.
Is it clear, ma'am? Is it loud
It's
and clear?
clear, but it's not loud.
Hmm.
Okay. Uh, I tried, ma'am. I will try. Generally, indices of resistance in MCA are low in association with fetal compromise,
Correct.
overlap with lower part of normal limit in many small fetuses. So,
Okay.
how can we differentiate and recognize the deteriorating situation?
How can we will look into the ductus venosus.
Okay.
We will look into the umbilical artery. Agreed. It is less than the fifth centiles. MCAPI is baby is IUGR. MCAPI is less than fifth centile. Agreed. CPR. We have CPR. We have umbilical artery. We will look into it because CPR again is telling us the status of both umbilical and the MCA. So we will look into that.
Okay. Okay, ma'am. Thank you so much, ma'am. The next question is from Dr. Swati Ahire. If mean uterine RTPI is at 3 at 12 weeks, what should be the management?
If uterine artery PI is at
3 at 12
3.
weeks.
Okay, 2.6 is our cutoff. It is 3. So uterine artery PI is increased. So that means the baby, the mother is going to either going to have preeclampsia or the baby is going to be IUGR. So we will start aspirin therapy 150 milligram OD for till 37 weeks.
Okay. Thank you so much, ma'am. I request all the participants, if you have any question regarding this topic, please put your question in the chat box. And thank you so much, ma'am, for this wonderful and very informative lecture. And thank you also for clearing our doubts.
Thank you.
So
Thank you.
now, on the behalf of NIMA OBGY Society Central and NIMA OBGY Society Maharashtra body, I would like to express my gratitude to NIMA Central.
Jagruti,
Yes, ma'am.
I would like to say something to regarding Dr. Priya Sahu, ma'am.
Yes, ma'am. Sure.
No doubt it was a brilliant talk, but she is one of the dynamic, youngest one, fetal medicine specialist from Nagpur. He has a very good talent, and she, you can, means from today you can judge how brilliant she is. And thank you so much, ma'am, for. Hello,
Thank you.
can
Thank
you
you.
hear
Thank
me,
you.
ma'am? Brilliant she is. And thank you so much.
Hello. Ma'am, your voice is not audible.
Yes, ma'am. Your voice is not audible.
Hello.
Hello.
Is it? Am I
Yes, yes,
audible
ma'am.
right
We
now?
can. Yes.
Audible, ma'am. Audible.
Okay. I just want to say thanks to ma'am because she's quite busy, and in that particular her time schedule, she give us a time and conduct this webinar very nicely. Most of them will get benefited with this knowledge. I truly want to say thanks for this. Thank you so much, ma'am.
Thank you, ma'am. It was an honor, and thank you so much for this opportunity. It was very nice to be here.
Thank you, ma'am. Thank you. Yes, Jagruti, continue.
Yes, ma'am. There are two questions in the chat box. Should I read, ma'am?
Yes, please, please.
This is a question from Dr. Anuradha Gupta. If there is a TR seen in anti-scan, how do we manage further, ma'am?
If TR is seen at NT scan, we would like to combine it with the biochemical screening or the double marker we have done. And also, if it is normal, that means we are ruling out chromosomal abnormalities. Second thing, what signifies tricuspid regurgitation, what is any cardiac anomaly. So we will ask the patient to do an early anomaly scan to rule out any cardiac abnormality, and we will ask the mother to do a fetal echocardiography at 24 weeks.
Hello.
Yes, Jagrati.
Yes, yes.
Ma'am, the next question is from Dr. Pooja Pandey. Does it happens that indices change from high risk value to low risk within a day? Is it scanning error?
Yes, it can happen. Grossly, it does not happen, but sometimes it may happen, depending on the sleep cycle or activity of the baby. But once we found it to be abnormal, we would like to keep the baby in radar, and we would like to repeat the Doppler again.
Okay, thank you so much, ma'am. So, if any participant have any question or query, please put your question in the chat box. The question is from Pooja Pandey, ma'am.
Okay.
After how many days should we repeat the scanning?
After how many days? How abnormal is the Doppler, first thing? Whether it is MCAPI, which is abnormal, whether it is umbilical, which is abnormal, what is the CPR? I've mentioned a chart towards the end, if you've seen. So you can go accordingly. How abnormal is the Doppler will tell us how frequent we should do.
Okay, ma'am. Thank you so much. The next question is from Dr. Brunali. How much difference between right and left MCA-PI is normal?
How much difference between right and
Left MCA-PI is normal.
right and left MCAPI is normal. Uterine or MCAPI? What are you talking about? We usually take one measurement of the middle cerebral artery.
Okay. She had
She must be
mentioned.
talking about the left and right PI.
Yes, yes, uterine. It does not matter. The mean PI should be normal. I'm talking about the mean PI. I've given the cutoffs of the mean PI of uterine artery.
Okay. Thank you so much, ma'am. Does anyone have any further questions? Ma'am, there is a question from Dr. Anuradha Gupta. Ma'am, if there is DV changes at 13 weeks and dual marker is high risk, is it indicated for termination?
First thing, DV has two significance. First is that chromosomal abnormality. Of course, the baby is at high risk for chromosomal abnormality. Second is DV is telling about the cardiac status of the baby. So we are suspecting any cardiac abnormality. So mostly when the DV is abnormal, the outcome is going to be poor. Either it is going to be a chromosomally abnormal baby, or the baby might have some cardiac defect. Only, as I mentioned, only 1% of the babies will have DV reversal, which will be normal. So that's very less actually.
Okay. Thank you so much, ma'am. The next question is from Dr. Pooja Pandey. How does site of placenta influences uterine artery PI?
Site of placenta, umbilical artery PI. The resistance or the of the umbilical artery is higher at the fetal end and the placental end. So it's best take a free loop, free flowing loop, and then take that is the best way to measure it. If we measure it near the fetal end, it will be high. So the resistance decreases from fetus to placenta.
Okay. She's also want to ask about umbilical artery PI, ma'am.
Yeah, this was about umbilical artery only.
Okay, sorry, uterine artery PI.
Uterine artery PI. What she wants to ask about uterine artery PI?
How does site of placenta influences uterine artery PI?
Site of placenta in uterine artery PI. I do. Matlab, there is no relation to it actually.
Okay. So, is there any further question? Or should we go for the vote of thanks? I think the questions are over. So I go with the vote of thanks. On behalf of NIMA OBGY Society Central and NIMA OBGY Society Maharashtra, I would like to express my gratitude to NIMA Central, Dr. Ashutosh Kulkarni sir, Dr. U.S. Pandey sir, Dr. Shantilal Sharma sir, for their remarkable support. I extend my gratitude to our NIMA OBGY Central President, Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakde ma'am, Treasurer Dr. Vishnu Bhavne sir, Convener Dr. Rajesh Utne sir, for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Priya Sahu ma'am, who took time from her busy schedule and delivered very knowledgeable and wonderful session and also cleared our all the doubts. I would further like to extend my gratitude to our NIMA OBGY Maharashtra President, Dr. Suhas Herlekar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Raj Bal sir, for their support to conduct today's webinar. I would also like to thank Dr. Girish Daga sir, Dr. Arpita Shah ma'am for all the help and technical support. And last but not the least, I would like to thank from the bottom of my heart to all the delegates for their participation and presence. Without them, this webinar would not have been possible and succeeded. And now, with due permission of all the dignitaries, I am concluding today's webinar. Thank you all for attending and hope you have learned and gained great knowledge from today's speaker. Thank you. Thank you, Dr. Brunali. Thank you so much.
Thank you, ma'am.